In this next section, we're going to talk about tailoring the pre-oxygenation method to the patient in front of you. There are several ways we can pre-oxygenate the patient. With a non-rebreather, with a CPAP, maybe we need to bag them and use a PEEP valve. We'll also talk about APOX in a later section. So what do we mean by pre-oxygenation? What do we mean by tailoring this? So it's not a one-size-fits-all approach. We're going to risk stratify our patient based on their oxygen saturation. The first group of patients are the lowest risk patients. These are patients that we can put on a non-rebreather and their oxygen saturations will be somewhere between 95 and 100. These patients are at the lowest risk for desaturation, and a non-rebreather is usually adequate for PreOx. Now, if I have them on a non-rebreather and that oxygen saturation isn't quite getting over 95%, I want to up the ante a little. In this case, I'll consider a CPAP or a PEEP valve with BVM. Lastly are the high-risk patients. These people have oxygen saturations under 91%. They may require some gentle ventilation during the apneic period. Let's talk a little bit more about each of these approaches. First off, the non-rebreather. So what do we mean by high flow? Well, we're talking really high flow. So a non-rebreather mask at flush rate. This means that we're turning the oxygen up to the highest allowed by our regulator. If you're using a wall mount regulator, it has the little ball that goes up to the top of the tree. That wall mount may say it only goes to 15 or 25 liters per minute. But the truth is, if you keep cranking that valve all the way up, some of these will flow as high as 30 to 60 liters per minute. And now when we get them at that flush rate, we're getting a true FiO2 of 90 to 100%. If we're flowing our non-rebreather at a classic flow rate, even 15 to 20 liters per minute, we're actually only getting 60% FiO2. Now remember, we want to wash the nitrogen out of the lungs. Well, we can't do that if we're only delivering 60% oxygen. So turn your non-rebreather up to flush rate. So let's say we have our patient on flush rate non-rebreather and we just can't quite get those sats up. Next, we want to try to up the oxygen saturations using CPAP. These are patients whose sats won't get over 95. Why is this? Why is this happening? So certain patients have alveolar shunting. These are patients with pulmonary edema or pneumonia, or even atelectasis. So not all the alveoli are participating in gas exchange. So pre-oxygenating with CPAP can help recruit alveoli. They pop the alveoli open and they'll increase the oxygen saturations. Now, certain patients are at super high risk, and we can't even get their sats up over 91%. As we talked about with the desaturation curve, these patients are high risk for desaturation. So after we push our medications, and we're waiting for them to kick in, there's a short apneic period before we intubate. And during this time, even before laryngoscopy, these patients are at risk for desaturation. These are the patients we might want to consider using a BVM on. So what's the best way to use a BVM? So make sure you have a good mask seal. A two-handed approach is best. Often, BVMs need to be squeezed to get oxygen flowing through the BVM. Know your device. Some of them will flow oxygen without squeezing, but many need you to squeeze the bag. And then lastly, if you can, use a PEEP valve. This is the best way to use a BVM. So when do we want to use it? Obviously, if the patient's not spontaneously breathing on their own, we need to ventilate them, and a BVM is a great way to do this. If their saturations are below 93% during the apneic period. So I'm pushing my medications, the patient's apneic, but I'm waiting for the medications to work before laryngoscopy. If their sats drop below 93%, then I want to give them a few gentle breaths through the BVM to optimize their oxygen reserves. Ideally, we do this on low-risk aspiration patients. When do I avoid this? So during the apneic period, if their oxygen saturations stay over 93%, then I don't need to risk aspiration by bagging them, right? RSI is generally a non-bagging procedure. And anyone who's a high-risk aspirator, we want to avoid ventilating them. But let's face it, all patients in the pre-hospital setting are high-risk aspirators. They like to call us after a big bolus of pea soup or some large sandwich from your local fast food place.